within 1 day of being on the mechanical ventilator. We know that diaphragm starts converting the type 2B muscle fibers very rapidly. We know that tracheostomies have inherent risks. There's actually a death rate from tracheostomies. We know in the face of this pandemic recently, we've been delaying tracheostomies for up to 4 weeks because of that risk of that tracheostomy spreading the virus. So we know that trying to prevent a tracheostomy is critically important. We know in the modeling that occurs is about 30% of hospitalized COVID-19 patients will require mechanical ventilation. We know mechanical ventilation has a lot of problems for these patients. Part of the solution is to maintain diaphragm strength. That's really what diaphragm pacing is about, maintaining diaphragm strength, overcoming ventilator-induced diaphragm dysfunction, and really it drives respiration with diaphragm pacing. And as I mentioned before, that we could decrease the 40% of the time of patients are spent weaning. And so with this knowledge, the FDA authorized just 2.5 weeks ago, I believe, emergency use authorization for the TransAir system. This TransAir system is kind of an outgrowth of our chronic system that we've been using for spinal cord injured patients for over 20 years. It's disposable, simple use, easier to place. I'll kind of go all of that in the next time period. We know that the NeuroRx, which is our chronic system, was initially for spinal cord injury. And it really set the stage for this newer system because we got a lot of knowledge about how we can wean a patient off the ventilator. We can take a spinal cord injured patient who's been on a ventilator for 10 years and wean them off that ventilator. I'm going to then just go briefly over that. And then I'm going to talk about how we implant this TransAir system. I'm going to talk a little bit about how the use of this can decrease mechanical ventilation. I'm going to review some data that we previously published. I'll tell you what we've done in my own hospital just in the last month. But really, it's about trauma and emergency abdominal surgery, cardiac surgery, medical intensive care unit patients where at the time of their tracheostomy, we might instead offer them laparoscopy beforehand. And I'll briefly talk on COVID-19 patients at the end. And kind of in the background, and again, I won't spend much time on this since many of you may know our chronic system, we can replace the ventilator for a high quadriplegic. Superman, Christopher Reeve, was the second patient I ever implanted. No spinal cord injured patient has ever said, you know, I like a ventilator over diaphragm pacing. Overall, in the world, over 2,000 systems have been implanted with 28 countries. There's been multiple publications. I recently published my long-term experience. We know that the earlier we implant for a spinal cord injured patient, the greater the success is. Kerwin out of Florida also showed that diaphragm pacing decreases early mortality rate. The less time you're on a ventilator, the greater it is for the patient. We know that if you have a pneumonia, diaphragm pacing helps to recover from that pneumonia faster. He also showed in a spinal cord injured patient, he could decrease the weaning time by 20 days, from 30 days to 10 days. That significantly would open up your intensive care unit if you have some spinal cord injured patients. That intensive care unit could then be used for other patients that may need it. And this is just a nice example of a patient that was transferred to me, a 16-year-old, broke his neck in a wrestling tournament. For 21 days, he was on a ventilator. Every minute of every day, he was trying to wean, but he's a quadriplegic. He couldn't really go off the ventilator. He was transferred to my institution. The 22nd day, I implanted him. The 24th day, I extubated him with no tracheostomy. As he says in a video, now look at my beautiful neck. He's still a quadriplegic, but he never had a tracheostomy. That first 3 weeks, he had no rehabilitation. And eventually, with diaphragm pacing, he had recovered some breathing. So he now does not even need diaphragm pacing. Again, a great example from our spinal cord data showing early implantation, getting somebody off a ventilator. We've also shown other areas about patients with pneumonias. If you're on a ventilator, we all know that you're going to get a pneumonia. It's hard to prevent that. His right lower lobe collapse because of an elevated diaphragm. We were able to start pacing that and prevent that atelectasis and eventually equal out the diaphragms. So we know in our spinal cord population, we can go from an average of 2 pneumonias a year to 0 with natural diaphragm breathing. All of this is critically important in all of our surgical and intensive care unit patients right now that might be on the ventilator in the intensive care unit. And really, why temporary diaphragm pacing? In 2008, the New England Journal had a great article that confirmed some of our animal research, showing that when you're on a ventilator, very rapidly the diaphragm atrophies and converts to this type 2B fast twitch muscle fiber. This has now been corroborated in multiple publications. And again, in the United States, we have over 400,000 patients a year on prolonged mechanical ventilation, which is greater than 72 hours, and over 100,000 temporary tracheostomies are performed. That's even before the present pandemic. We know that tracheostomies have a significant complication. We know that the annual cost for prolonged mechanical ventilation is significant. We know that overall, it would cause some significant problems for patients, and that cost is just part of it. There's morbidity and mortality, long lengths of stay, all those things we can help to address with pacing. We initially did a feasibility trial showing that these temporary electrodes can be placed fairly easily at the time of other operations. This is kind of a proof of concept to actually show that we could place them during a median sternotomy. You can see our little temporary electrodes here, cardiac pacing wires. We confirmed success. We confirmed that we can just place these electrodes in the usual standard location without what we call mapping that we had to do with our chronic system. And we could get a tidal volume over their predicted need. So we can drive ventilation in these patients. The conclusion of this trial was that diaphragm pacing can be easily placed. It can be removed. It's safe to do in these patients. And as an example, this is typical in our elective world of surgery. You might address this. And we showed in a patient like this, we could fix that massive abdominal hernia, put in the drains, and have some temporary electrodes. They would stay throughout that patient's course, again, showing that through complex abdominal surgery, we can place these electrodes fairly easily. Again, laparoscopically, I'm going to kind of go over this briefly because I have some videos from a case just 2 days ago I did hit in my hospital. They'll show how we place these electrodes in standard laparoscopy. Fairly straightforward for any laparoscopic surgeon. Again, this is the right diaphragm. This is the new electrode. We can just grasp the electrodes to pull them out, or we can use a Keith needle, and we just suture the electrodes on the skin afterwards. And I'll go a little bit more in depth with this later. And again, I'm kind of show by cases. These are all cases that I've had just in the last month. So in April, I had a patient with a transferred to me after tracheostomy, ventilator dependent for 30 days. It was in Columbus. He was transferred to Cleveland. He had severe bilateral diaphragm dysfunction. One diaphragm had already had problems during an open heart operation previously, and then he had a sudden problem in the other diaphragm. He was admitted with a significantly elevated PCO2, was intubated, had no diaphragm movement, tracheostomy. In our state of Ohio, as we were preparing for the pandemic then, he could not get a home ventilator. And so he's just been sitting in a hospital. He's transferred to us. I took him to surgery on the 13th of April. I removed his tracheostomy on the 15th of April, 2 days of diaphragm pacing. His PCO2 while he was trying to wean on the ventilator was 56. With pacing, after pacing for a full day, was 43. We were able to completely drive his ventilation. Again, this is an extreme example of how quickly we can help these patients with adding diaphragm pacing to their weaning regimen. And again, this patient showed that extremely elevated diaphragms, collapsed lungs. You see his tracheostomy here. This is shortly after surgery. Tracheostomy is removed, greater lung volume, still has a little weakness of his left diaphragm, but obviously enough to get him off the ventilator, off the tracheostomy, and he can go home. We had previously looked at some patients in our medical intensive care unit. We had presented this last year at the ATS meeting with a total of 22 patients. And again, these are patients on mechanical ventilation for an average of 80 days. And we could still adding diaphragm pacing can wean them significantly. Again, showing in a kind of a medical or surgical intensive care unit success on these chronic patients on a ventilator by just driving their diaphragm, overcoming ventilator-induced diaphragm dysfunction, and kind of helping maintain their respiration. This is a case again that April 22nd. This is how rapidly we've utilized this in our facility with the new emergency use authorization from the FDA. Patient with Marfan syndrome, very difficult, complex aortic reconstruction. You can see obviously this aneurysm here enlarging, higher risk patient, had a prolonged initial operation, left his abdomen open, he was intubated. We knew in that 48 hours, you can see his right diaphragm significantly elevated. This was probably pre-existing this operation. We took him to surgery at the time of his redo exploratory laparotomy. They had to use component separation to bring his abdomen together. They placed the electrodes. You can see some right here. The electrodes being placed just in the abdomen at the time of that operation. And here's what we were able to do. That same day, we turned on the device, or we were initially trying to extubate him. They put him on BiPAP. His PCO2 was elevated. Tidal volumes on BiPAP was just 500. We just added diaphragm pacing. Tidal volumes went up. PCO2 went down, and we were able to help him not get reintubated, keep him off the ventilator for this prolonged postoperative course. We were able to extubate him really that first day by adding diaphragm pacing to him. And again, this is his improved chest rate afterwards, and I'm going to show you this video here. He's about ready to go home, so it's one drain. This is yesterday. We can pull these electrodes out. There's one electrode coming out, the other electrode coming out. Pretty straightforward for this patient. Again, he was managed on the floor with the system. He has his drains, his abdominal operation, the electrodes sitting on his upper abdominal wall. And we can just, again, just pull out these electrodes since they're not tunneled anywhere, simplifying his postoperative care after a major abdominal operation, two major abdominal operations within 24 hours. And this was yesterday. I pulled these electrodes out and he was discharged today. I'm going to talk a little bit about cardiac surgery, and this is very important. We know that prolonged mechanical ventilation in cardiac surgery significantly increases the cost and the morbidity for these patients. If a patient actually is on a ventilator for about 12% of all open heart operations are on ventilator 24 hours, and 4% required after 4 to 5 days. Their complication rate goes up significantly, the infection rate goes up, the operative morbidity and mortality. All these problems develop once you cannot get off on the ventilator. So we had previously looked at cardiac surgery as a good example for adding these electrodes during a median sternotomy. And I'll show you how we place these electrodes. This is a median sternotomy, end of the case. This is the patient's right diaphragm. And again, almost every cardiac patient gets temporary cardiac electrodes. We're just adding temporary diaphragm pacing electrodes. You can put them in, fairly straightforward. The needles are brought out, and then we just tunnel them similar. You again can see a recent bypass graft, the same type of Keith needles to bring them out. With extra slack, and it's just like the temporary cardiac wires. This is on the right diaphragm. Cut the Keith needles off and just suture them to the skin. Fairly standard for open heart operations because it's done on every patient that for temporary cardiac wires. I'll again show you the same thing on the patient's left diaphragm, just gently pushing on the heart. On some of our cardiac surgeons, now we're just doing this while the patient's on bypass, because then actually the heart's not filled up. This patient is not on bypass, so it's done at the end, the left pleural space. And again, the second electrode going in. Again, these are relatively unedited videos. You can see it can be done fairly rapidly at the time of an open heart operation. And this is what we can do afterwards. This is a patient, a very high-risk cardiac patient. He's needed a bypass before a liver transplant. We actually added the diaphragm pacing. He went to encephalopathy. And while he was awaiting his liver, he was actually breathing just on CPAP. The pacing was driving his diaphragms. Tidal volumes and minute ventilation were very adequate. So we're preventing diaphragm atrophy, decreased airway pressure. And actually, in this past week, after a liver transplant, he finally woke up and we weaned him off the ventilator in less than a day after being on a ventilator for 21 days because we're maintaining his diaphragm the entire time. So this is kind of, again, showing having the ability to have these electrodes in at another major operation allows you to change the postoperative management. This patient would have been on, SIMV for 21 days, but instead we were just managing with CPAP afterwards. We had shown previously in an article in a presentation several years ago that we had this positive effect on patients that actually were either tracheostomy or completely dependent on positive pressure ventilation. And adding diaphragm pacing when you had an injured phrenic nerve had complete recovery in 9 of 10 of these patients. We had also recently last year in Berlin at the European Society of Critical Care Medicine, we were up to 23 patients. Again, in 20 out of 23 patients who had an injured phrenic nerve on mechanical ventilation for a chronic period of time or non-invasive, we were able to get complete recovery of that diaphragm. So we know that this can occur during cardiac operations. If we have the electrodes in at the time of the surgery, we can start that rehabilitation much earlier. And again, I'll show you an example of a patient with a left ventricular assist device, elevated diaphragm, and we got complete recovery of the diaphragms, allowing him, you can see his left ventricular assist device, diaphragm pacing, allowing him to be eligible for a heart transplant. So it really changes what we can do for these patients by having the ability to get them off the ventilator. We had also shown Europe with several different groups in Europe where this device has been already approved, is that we can do it during bilateral lung transplantation, Leuven, Belgium. In Murnau, Germany, they've also been utilizing this device during their trauma operations. Again, showing the safety of this in multiple countries of this new temporary diaphragm pacing system. Now I'm going to show some further cases with us. This is a 55-year-old patient with unstable angina, BMI of 45, dependent on BiPAP, elevated right diaphragm non-functioning. He had a CABG ×4 on 427. This is an immediate postoperative chest x-ray. This is obviously pre-everything. Elevated diaphragms, even worse. We had placed the electrodes at the time of surgery in case there's a problem. And we just started pacing them. It allowed us to extubate them fairly rapidly. And again, here he is on yesterday, getting ready to go home. And I'm pulling his electrodes. We just gently pull them and they can come out. You can see on his abdomen here, cardiac pacing wires in. So again, an added thing to have during high-risk cardiac surgery. Patient has a problem, we have the ability to pace them. The electrodes can be removed just as easily as temporary cardiac pacing electrodes. I'm going to show this other one in just a second here. Just to give you a background, a 72-year-old gentleman, again, transferred to our hospital for urgent, somewhat emergent coronary bypass, preoperative chest X-ray, severe pulmonary fibrosis, elevated diaphragm. We elected to place the system at the time of the operation. We then just, as soon as the neuromuscular agent started wearing off, we started pacing him. This is how simple it is to put this device. We just attach the device to the electrodes. That's on the left side. To the right side, color-coded matching for each side. And then it's just like a temporary cardiac pacing device as opposed to our chronic system. You'll see me hold it up here in a second. We can hit the two buttons to turn it on. Then I hit the unlock button. The device will work for 30 days. And right now you'll start seeing there's all checks. We're actually starting to stimulate them. And all we do is set his respiratory rate, his inspiratory time, and then we just kind of increase the intensity. I can change which side I'm going to pace. I know his right side is his much weaker side. So I'm going to actually increase the settings on his right side and decrease the settings on his left side. As they're waking up, we make sure they have no pain or other problems. So I can turn off one side. You'll see me right here. I'll increase the settings on his right side. I'll turn off the control on his two right side. I'll control his two left ones. And right now, I'll decrease the settings a little bit on his left side. It's fairly straightforward on increasing these settings. We go up to as high as they can tolerate as they're slowly waking up. They usually will not feel this at all. Right now, you can see the device working on all 4 electrodes. We're stimulating him. We'll start helping him wake up from the anesthesia and hopefully not get reintubated. Again, this high-risk patient, 8 hours post-op, he was extubated. We actually today, he's still doing fine, up and talking. He's actually wearing this device now. We'll work out his right diaphragm some in the perioperative time period. Again, this is another patient. This is a patient who a week ago, last Wednesday, had a high-risk operation, 72-year-old, congestive heart failure, again, morbid obesity, on a balloon pump preoperatively, congestive heart failure, chronic renal failure, is a redo median sternotomy. All these things increase that risk for it. He had a mitral valve replacement, tricuspid valve, bypass time fairly long, OR time fairly long. He was unable to be weaned after this operation for 1 week. And at this point in time, there's consideration for a tracheostomy. Instead, we took him to surgery to add diaphragm pacing. And I also placed a gastrostomy tube on him at the same time. And again, this is the video showing placing these electrodes. This is, again, Wednesday of this week. It's fairly straightforward. We kind of know where the diaphragm is on the right side, not on the central tendon. This is the first electrode going in. I'll pull we want to stay just in the diaphragm muscle. Kind of pull the electrode into that area. I'll then grasp the proline, not the needle itself. I'll then pull that electrode into the muscle and through the muscle, actually. Just superficial, doesn't need to be too deep. I'll then pull it up this way. cut the needle off and bring it out through my abdominal wall. I think I'm waiting for my resident to cut the needle, the suture. We'll cut that out and bring it out like you would for any other laparoscopic needle. Place one electrode. We put 2 electrodes in each diaphragm. I always put the posterior one in first, which is the first one I put in. This is a second electrode going in. Actually, this patient, you can see him, the movement of the diaphragm a little bit, that's from his ventilator, not from him. As opposed to our old system, we can actually use a brief paralytic in these patients. Again, pull the electrode through, cut the needle off, bring the needle out. And then just me positioning the electrodes. I want that barb to be in there. So I'm going to kind of pull it a little bit. Kind of positioning it there. The exposed part, there's a few millimeters of exposed electrode that's in the muscle itself. And then I just bring the electrodes out. I have a Keith needle there. I'm just pushing it through the anterior abdominal wall. I can also use a Carter Thompson to bring that out. And again, I'll just pull the extra slack out. All the extra slack will be out of the abdomen. It should be easy enough to pull this out at the end, just like leaving a drain in anybody. A little slack on the inside. And this is the patient afterwards. You can see he was a fairly large gentleman. See the gastrostomy tube I'd placed. Here's the system. We actually started pacing him in the operating room. And actually, on the next day, which was yesterday, 23 hours after being a week on the ventilator, we actually extubated him. He's still continuing to do fine today. I think he's being weaned off all of his medications. The key aspect is he no longer has the ventilator, which is a huge benefit for him. And again, this is really what we're trying to do, is to change the paradigm of the intensive care unit. We can actually treat that ventilator-induced diaphragm dysfunction. We can actually make sure that these patients are getting the right, decreasing the tracheostomy. We can decrease the pneumonia rate. It's kind of this whole paradigm, posterior lobe ventilation. We really are changing and maintaining negative chest pressure. Like that one gentleman awaiting a liver transplant for 21 days, or roughly 14 days and another week waking up after his liver transplant. He was just maintaining negative chest pressure. Breathing almost naturally. He couldn't drive that ventilation, but the pacing was. All these things that we can do, increase the strength of the diaphragm, prevent ventilator-induced diaphragm dysfunction, prevent that atrophy, maintain the good muscle fiber, and really at the high-risk patients, placing at the time of surgery really helps these patients. When I look at my own hospital, just in the last month, in April, we've utilized this technology in 28 patients. There's 6 patients that we placed the chronic system on, the NeurRx. They were all in mechanical ventilation for chronically, 2 acute spinal cord injured patients and 4 with chronic injured phrenic nerves. One patient had been in our hospital or had been in a hospital for 4 months after a lung transplant with an injured phrenic nerve. We were actually already have them down to pressure support after a week of utilizing this. And then the translock system, once it was approved, we were able to place this in 22 patients. We could place it be laparotomy, laparoscopy, or median sternotomy. And the interesting, we placed them in 22 patients. It's nice to have. And we only used the stimulation in 11 patients. It's kind of this benefit that you have on a high-risk patient. The patient does well, you just pull the electrodes, just like placing a drain. If the patient does well, or a chest tube, and you don't need it, you pull this. For 11 of these patients, we were able to stimulate them. And to date, at least in this short time period, no tracheostomies on these patients that we decided to pace. And some of them, actually, we would have expected that, especially the gentleman who roughly for 21 days, he was just on the diaphragm pacing after open heart operation. To date, all the electrodes have been able to just be removed at the bedside. There may be some cases with anticoagulation where we may have to do what they do for temporary cardiac pacing wires, but to date, because they come out so much easier with the design, we're able to remove them. So overall, and kind of the conclusions that we have, it's kind of straightforward. All spinal cord injured patients should be offered this technology. The data, we've been utilizing this for 20 years. We know that high surgical risk patients should have the temporary electrodes placed at the time of their laparotomies. They can be done very easily. You can see the diaphragm, especially for upper abdominal operations. We know for high-risk cardiac patients, there's some straightforward patients that you would expect to do very well, but the higher risk ones that you can predict fairly well, you have these electrodes in, you can just manage them if they have a problem perioperatively. And this is where we're really looking at the patients being considered for tracheostomies. Fortunately, in Ohio, we have not had, especially in Cleveland, we've not had a huge problem with the COVID-19. We've not had to do a tracheostomy on a patient to date, which has been, we have several patients on bypass, some problems right now, but right now we have not had that need for them. So we expect, before I would do a tracheostomy, if it's truly over their acute episodes, I would consider diaphragm pacing on these patients. If it's ventilator-induced diaphragm dysfunction, lack of ventilatory drive, and they're stabilized from the oxygenation problem, because again, it's mostly an oxygenation, diaphragm pacing is mostly to help with the ventilation for CO2, they can be placed. But really, in our ICUs now, we're considering this in anybody for tracheostomy. It makes sense to prevent that for these patients. It really is a fairly simple concept. If you can drive that diaphragm to work and move, you're going to ventilate the patient. So with that, I'd like to thank you all for attending and kind of listening to me for the last 30 minutes. As those of you that have heard me talk, I could probably talk for 10 hours on diaphragm pacing after working on this technology for 23 years. And right now I'm going to try to open up for any questions on the Q&A. And I'll try to also look for the chat if you do that. And again, I thank you for joining us today, and hopefully this will help your patients. I think preventing a tracheostomy, weaning off the ventilator, is significantly important for our patients. So there's the Q&A question. If anybody has one, I'll answer it. The first question was, where are the electrodes placed with respect to the phrenic nerve branches, and how does the pacemaker change the mechanics of coughing? I'll talk initially on the first one. In our long experience of diaphragm pacing, we actually have realized that we can map out the diaphragm, but there's usually, with a very great chance, that you'll be able to just pick the spot. You won't place it on the central tendon. On the left diaphragm, you're going to be lateral to the heart because the phrenic nerve comes laterally. And you'll just place the two electrodes. So it's usually a crossing vessel. The diaphragm is one of the only muscles that the blood supply comes from below and the nerves come from above, but they're pretty close together in that area. On the right diaphragm, we just go lateral to the central tendon. The diaphragm pacemaker will not change the mechanics of coughing at all. And so for a patient that would want to cough or breathe over diaphragm pacing, they can. We always think it's very important for the patients to work on their coughing. In the ICU, they can still do other exercises. We're just maintaining that diaphragm strength. What we know in the intensive care unit, many of our elderly patients lose their ventilatory drive. We usually try to wean just during the day, right? The patient's up, sitting up, and then at night they fall asleep, and it really, they don't breathe on their own. With the pacer, it's like physical therapy, 24 hours a day, they're utilizing it. The next question is, looking forward to getting more info. Do the acute patients feel any discomfort? Vent to synchrony. That's a great question. So a patient can feel discomfort because they do have sensation to their diaphragm. And again, I'll show you in our device right here. So again, if you can see this here, you can very easily change the intensity. So this is at the bedside. By just increasing or decreasing the intensity, you can decrease the pain sensation they have. We've actually learned in our initial spinal cord groups what it takes to pace the diaphragm. So you can't go over those settings for these patients. And actually it works fairly well for these patients on just going up and down. And because we're just like the patient breathing on their own, patients actually, as a patient can breathe over the ventilator, this can actually may or may not be asynchrony. Our way of weaning the patient with pressure support, this will drive that ventilator, and the ventilator will augment their breaths for the patient. And the patients I've done this past, at least 11 with the system in the last several weeks, we've had no ventilator dysynchrony. How do we define high-risk cardiac surgery patients? By Dr. Kerwin, who I cited earlier today, who's really done great work in the spinal cord injured patients, is that the STS database is very particular for high-risk patients. There's about 9 different criteria for them. We know reduced sternotomies are high risk, age over 70 are high risk, history of a stroke in the past, history of diabetes mellitus, if you have an intra-aortic balloon pump, if your ejection fraction is less than 20%. And so those are pretty standard in our STS, Society of Thoracic Surgery, guidelines for high-risk bypass patients. And so those are the ones that we're actually looking at for these patients. We also know for our lung transplant, our heart transplant patient, those are the ones that we've actually routinely been implanting since this approval has gone. We've been fortunate enough to have two lung transplants and two lung transplants and one heart transplant in the last weekend alone. And we placed the device in these patients. We're utilizing it in one of our lung transplant patients, one of our heart transplant patient. The other lung transplant patient, we just pulled the electrodes off. That pulse generator, there's a question, I think I'll show it right here. As opposed to our other system, all we do is put the electrodes in this clip lock and just snap it in. So there's nothing else to do. They just snap in, and this will hook to the device. This is attached to the patient's skin with a little bandage, a little their grounding wire, a patch. Then we just plug it in that way. So you just put the two electrodes in the end here and snap it on and off. So it's much simpler than our older system itself. There's a question on, does pacing muscular resistance rise and become a problem? Our resistance for our electrodes, so we have two things we do. We measure resistance to our electrodes on every time we pace the patient. We've not had a problem with muscular where the patient's fighting our device. Once a patient's wide awake and is breathing on their own, and you can turn this off and see if they're doing fine, you can also turn off the pacer. This device for patients that aren't quadriplegics, we're just augmenting their respiration. And I think, as we all know, we've all had our elderly patients that had a major operation, had that complication, and it's like they've lost their respiratory drive. And that's what we've identified. Some of my other research, we actually read their diaphragm electrodes that we have inside, and we can see what happens overnight. There'll be these prolonged apneas. All of our research shows that if you don't use your diaphragm, just for even 8 to 12 hours, you're getting atrophy. This allows these patients to just drive their diaphragms and prevent that atrophy overnight. I hope I answered, Dr. McFadden, your question about muscular resistance. We've not seen a resistance to the electrodes. The same electrodes that we're using now, we've actually used for up to 20 years on quadriplegic patients. The difference between this electrode is that it can come out easier than our chronic electrode. Obviously, that's for temporary use, along with a much simpler device to actually at the bedside program these patients. And I hope that answered your question. I know I always speak fast, and everybody says, I'm sure, I think the company may put this up on their website, Samus Biomedical, so you can look at it again. And again, I was just, these case examples have been very fascinating. And obviously, in our ICU, since we're so used to this, it's become, well, we have this patient right here, and you're weaning this other patient that happened to have the electrodes. How can we get him in this patient? And we can do it, basically at laparoscopy. And so that's what we did in that one cardiac patient, and some other patients in our intensive care unit that had the same problem. I think for some of our spinal cord injured patients, we'll also notice there'll be, we could on the ones we think we can wean. The sequence for programming, and this is one of the benefits. And those of us, and this is from Dr. Debo from Detroit, who's actually used our chronic system. He'll like this because it's much easier. Again, I just turn this on, and hit one button for the intensity, and I just increase the intensity. And we kind of know the rate that you have. It's pretty standard, what rate breaths per minute. It could be 10 breaths, 12, 18. Most patients in RICU will be between 16 and 18. And then we just increase the intensity. And we can we'll have a global across all 4 electrodes. If a patient would have one pain, it would be referred to the left or right shoulder. I can decrease the settings on that side and take care of it to decrease their pain. We try to make sure we set this enough that it'll trigger their pressure support. At least my usual mode of weaning these patients, if I can trigger pressure support, then I can actually try to wean them off that pressure support for the patients. And again, once a patient kind of wakes up and can do it on its own, you can turn it off, see how they do. I didn't show some videos of this on and off on patients in our intensive care unit, especially our one patient waiting for liver transplant. He had some baseline breaths that were much shallower. We add this, we're able to maintain that tidal volume. Again, we also know when you're pacing with the diaphragm, we're driving that air to the posterior lobes. We know the respiratory compliance goes up. We know as your respiratory compliance goes up, there's less atelectasis. It's more natural than all positive pressure ventilation. Again, I'll put my email back up on the slide. It's right down here, raymond.onders@uhhospitals.org. Feel free to email me if you have any other questions. I know we all are on Friday night or Friday afternoon. I still have to round, and this is where it kind of can work. My cardiac surgeons have gotten very adept at this, but we probably have 10 patients in the hospital right now with diaphragm pacing electrodes presently. And so it's been, all my patients are in some type of protocol where we're following them, but other patients, they can just place it at any time. We found it very helpful in our intensive care unit on utilizing it. And it's interesting aspect is that, in our cardiac ICU, every patient has a temporary cardiac pacing box, and they have a temporary diaphragm pacing box now if they need it. And it's actually been very well accepted very rapidly by our nursing staff without much change for these patients that already have temporary cardiac pacing wires. And really just the benefit of having this in case the patient has a problem, especially that second look laparotomy that we did where we were kind of debating, we kind of extubated him, we had the electrodes in, and he wasn't doing well. And then we just add diaphragm pacing, and there we could very quickly see how we can change that, prevent that patient from being reintubated. So I think as the questions seem to be going down, I don't want to just continue to take up any of your time again. And thank you all for being part of this. And again, I think it's been exciting as we were working on these patients. And here's one more question is, this is a very good question is, am I doing the implants or the cardiac surgeons? Actually, I scrubbed in on the first case with the cardiac surgeons, and they actually, it's very easy to see the diaphragms, and the electrodes are very easy for them to put in. They just put them in routinely. Today, in our city of Cleveland in Ohio, we had some of our first relatively elective outpatient surgeries allowed. So I was at one of our outpatient surgery centers doing some laparoscopic gallbladder surgeries this morning. And my cardiac surgeons at the main hospital put the electrodes in. And one of the cases, they kind of said, well, we weren't planning on it, but it became a much more complicated procedure. They have the electrodes coming out. And actually, they know how to block them now, and they'll just wait and see. It's kind of, as we like to say, is when you realize on your other patients that this can help them, and literally you have a box of electrodes at your disposal in your cardiac room, it's easy to put them in if you have any concern for that patient. It's better now than they have to go back in like I did in that one patient on Wednesday to put the electrodes in laparoscopically at a second operation. I'm looking to see if I missed any other questions. There's a question here that I missed earlier, and where do we place the electrodes? And we're at the phrenic nerve branches. And so if I'm in the chest cavity, in the left or right chest, you can actually see the phrenic nerve going into the muscle. And so we just put it in the muscle next to the nerve. We're indirectly capturing the phrenic nerve, but we aren't near the phrenic nerve, so we don't risk injuring the phrenic nerve. Laparoscopically in the abdomen, we, over the years of doing this, we kind of know the spot is by that one vessel on either side, lateral to the pericardium on the left. And we just place the electrodes there. One of my concerns early on, which is the reason we did the pilot trial, is could we, without mapping, identify and get a big enough diaphragm contraction? And we can. And so we showed that with greater than 100% predicted tidal volume for these patients. That's the reason I did that pilot trial, to show that we didn't need to map in a normal, a non-quadriplegic diaphragm. And it's kind of a feedback. Once we start getting that diaphragm to contract, the patient will contract with it. So we're just kind of, I like to say to some of my residents, the diaphragm pacing is like the preboscillary complex, the lateral medulla that's not driving ventilation in these patients. We're just causing that diaphragm to contract at a set rate to prevent that diaphragm atrophy and to prevent the conversion of type 2 muscle fiber, and really changing the physiology of ventilation. I'll kind of scan. I hope that answers your question on where we place this. And fortunately, we were able to do it in that pilot trial. We showed that area. I think I've caught most of these questions here. I think it's been 45 minutes on a Friday afternoon. Feel free to email me any other questions or anything else. And with that, again, I thank you all, and I hope you all have a very safe weekend. And with this, I'll kind of sign off my screen.